on behalf of the Future African Plastic and Reconstructive Surgeons Association, we'd like to extend a special welcome to all our members. A bit about AfroPRS. It's a vibrant community of medical students and young doctors from diverse backgrounds across Africa. We are united by our passion for plastic surgery and our commitment to the advancing of this practice in our continent and advocating for it globally. Our mission is to foster a collaborative environment where we can learn, share knowledge, and become leaders in the field. So today we are excited to bring you this critical topic of cleft lip. As Dr. David Albertson once noted, the greatest wealth is health. And so in the next 1 hour, we'll delve into cleft lip and palate. We encourage you to ask questions and share your thoughts all through the webinar. We are very honored today to welcome Dr. Michael Goldwasser as our speaker today. He is a distinguished maxillofacial surgeon with over 4 decades of experience. And Dr. Goldwasser holds multiple degrees, including a Doctor of Dental Surgery from the University of North Carolina, Doctor of Medicine from Northwestern University. Currently, he serves as chair of the Surgical Council on medical oversight at Operation Smile, as well as being adjunct professor at the University of Maxillofacial Surgery in North Carolina. So his extensive background includes significant contributions to multiple medical missions across several countries, providing surgical care to underserved populations and leading innovation to treating of craniofacial anomalies. So tonight he will share his insights with us, and I'd like to ask all of us to please join me in welcoming Dr. Michael Goldwasser.
Thank you very much. I appreciate your kind invitation. I've talked with Alice quite a bit about the presentations and about the forum that will be here. On the scene, I have the picture of the future African plastic and reconstructive surgeons, and I'm glad to be part of this project. My background, which I would like to share with you, is that I started quite a few decades ago and had the opportunity to watch a very talented surgeon go to the operating room. He invited me to go there, and I watched him take a bone out of a girl's leg, make a new jaw, and I was like, oh my goodness, this is what I want to be when I grow up. And he said to me at the time, he says, well, you have to go to dental school, and you have to go to medical school, and you have to do surgery, and you have to do craniofacial work. And by the time you're done, you will be old and bald. And for sure, I am now old and bald, but I can do the surgery. So I feel very fortunate that I was able to follow in those footsteps and was able to continue my career. Today, this is the lecture I give summarizing cleft lip and palate care, and I usually give it to medical students at the end of their training, and then residents years 1 through 6, and fellows. So this is not the lecture that's given to very experienced surgeons who have all this database at their fingertips, but it's more of how do we get to understand more about cleft lip and palate. So I will try not to insult any of you. On the window that I have, I can't see if you're raising your hand to ask a question, but you may ask a question at any time. Just one of the host will have to just interrupt and say, wait a minute, can you talk about? And I'm happy to do that. So as I said, I'm an adjunct professor, a full professor of surgery at the University of North Carolina, both in craniofacial and surgery. I joined Operation Smile many years ago, and I have continued as chair of surgery for a number of years now. Prior to this, I'd worked with another organization traveling mostly to the Philippines and Central and South America, doing the same thing but overlapping completely with Operation Smile. I have now joined this group. There are a number of groups in the world that do this kind of care. It just happens to be the group that I've fallen in with and felt that best met my needs. So today I'd like to talk a little about the demographics. These are just so you have the facts in your head, some of the initial embryology which you had in the early years of medical school, and then talk specifically about surgical management, which is of course what we all love to do, regarding cleft lip, cleft palate, and velopharyngeal insufficiency. Now, I am not the know-it-all, the guy that says, this is my way, if you don't do it this way, it's not right. I don't believe that. There are many ways to do this, and I'll show some cases of my work, which I'm not very proud of, and some that I am proud of, and I'll show a few cases of some of my colleagues. The facts are pure, but the techniques can be modified, and each of you will learn from whoever your mentors are in the operating room to say, well, this is the technique I learned, and it's what I like to do the best. And it's where my most predictable results are. And that will be what you will choose, and it will work for you. But we all continue to stand on shoulders of others to try to learn better ways. So what's the incidence of cleft? Well, worldwide, it's about 1 in 750 to 1 in 800 live births are born with cleft lip or palate, as opposed, and of that group, 10% have congenital heart disease. So you have to think about every time you see a kid, make sure you check for other anomalies as well. In the United States, it's about 1 in 750. In the Caucasian population in the United States, it's about 1 in 1,000. In the African American population, different than the African population, but same genetic pool, it's about 1 in 2,000. In the Philippines, which is where I traveled for many years, it was about 1 in 80 babies are born with a cleft lip or palate. And you say, well, how could it be so many in that one country? And what you have to think about is that the Philippines are an island country, multiple islands. People, it's a very poor nation. People are born in one area, they grow up in that area, they get married in that area, and they die in that area. And their gene pool keeps getting less and less spread out, and they get more concentrated, and so there are more clefts. I would typically go to the Philippines for 2 weeks, or about 15 days. I would operate for about 12 days. In the time I was there, in our team, more children were born with clefts during that 2-week interval than I had the opportunity to repair. So we kept losing, but now there are enough surgeons who are trained and more people that we're starting to turn the tide on catching up. And in some of the countries in Central and South America, we are catching up. And in some in Africa, we are also catching up. But we need more qualified surgeons like yourselves who will be able to help stem this tide and treat these children. So the incidence of lip is about 24%, more common on the left than on the right. Bilateral lip is only 4%. A unilateral cleft lip and palate is about a half of all the kids born. So just talking about the embryology of this, these are the words that all of us use. The ovum is from the date of conception until the 7th or 8th day. The embryonic period is from the 2nd to the 8th week, and then the fetus is after that. And without getting into any of the discussions about rights of women to do things, which I greatly believe in, this is the terms that we use to describe the ovum, the embryonic period, and the fetus. So when you think about this, to the end of the embryonic period is to the 8th week. We'll talk about how long it takes for a cleft lip and palate to grow. So this is the early embryo, and this is where the mouth will form. This is where the head is coming down, and this opens up into the mouth and then into the gut. And this is the embryo. So at the 4-week embryo, this is what it looks like. The eyes are on the side, the nasal pits will be here, the mouth will be here. And then we talk about our first and second branchial arches and what they do to help in the growth of the embryo. Now this is at 4 weeks, 28 days. This is the 5th week. You can see the eyes are starting to move a little, the mouth is opening up, the nose is coming together, and the eyes are still starting, the nose is starting on the side, and here's where the mouth will come. You see the mandible is coming down here, and this is how the nose would form. These are the 2 nostrils. The eyes are all the way on the side, and the nose is starting to come in, and you can imagine what a cleft looks like, where it does not fuse together. It fuses right through here. So if you think about where this cleft is, this is about 6.5 weeks. So Classically now, a lot of women don't know if they're pregnant if they miss their first menstrual cycle, and that's 4 weeks. A lot of times they will not check for another few weeks to check a pregnancy test to say, am I pregnant or not? By the time they get to 6.5 weeks, or about 42 to 45 days, this is when the lip will close. A lot of women don't even know if they're pregnant at that time. So by the time they get to do their pregnancy test, the lip is already formed. And if they had been doing things like taking any drugs that might cause deformation, they're already out of the window of what might cause a cleft lip to occur. So it's very challenging. Now, clearly there are early pregnancy tests that can be taken that will allow women to know earlier, but still, if they're planning pregnancy, you want to try to do everything you can to avoid anything that could cause anomalies. So here's how the lip and nose come together: the medial process, the lateral process, maxillary process. It comes together to form the lip. And this is where the lip would come together. And you can just think about all our kids that we see where there's a hole here and it goes up into the nose. So the medial nasal process forms with the lateral nasal process to form the nostril, and then the maxillary process moves around. So this is at 7 weeks. The lip is already fused at this time. So these are just early studies. The palate, however, closes about 7 to 8 weeks. So it's about 50 days to 55 days is when the palate would close. And the palate forms differently. The palatal shelves sit so they're like this with the tongue in between, and as the tongue drops down, the palatal shelves come up. And as depicted here, this is the median process, which is, if you think about a bilateral cleft, this is where the segment is anteriorly from the frontal nasal process, and these are the two lateral palatal shelves. And they start separated so that this is how it looks in the other plane. This is the tongue sitting up between the two palatal shelves. And at about 49 days, the tongue will drop down, the palatal shelves will rotate into place, and you'll get fusion into the center of the palate. So this is what it would look like, tongue drop down. So if the tongue doesn't drop down, the palate doesn't close completely. The palate closes from the front to the back. So when you think about looking in these babies' mouths, if the front is open, the back would be open. But sometimes there's an incomplete cleft where it starts fusing at the front, but doesn't completely fuse into the back of the palate. So a lot of people have come up with their own nomenclature of how they're going to assign what the clefts are, whether it's a unilateral, bilateral. They all come up with their own, and there's nobody that really has any overt wisdom about what the definition should be. For me, it's more you just describe what you have. You can use this definition, you can use that definition, but in general, it's a cleft of the palate or a cleft of the lip in the palate, and you can go with a bilateral cleft, a unilateral cleft, but it's all just basically describing what you see. So typical unilateral cleft, this is the cleft of the palate where you see the blue line here because the muscles have not joined together, and a classic bilateral cleft taken with the kid already intubated, ready for surgery. This is the cleft of the soft palate. This is touching only because of local anesthesia. So this is my favorite. This is how the embryo forms, and I like to show this because here are the eyes on the side. This was done by some students. The eyes are on the side. Now it's coming together. You can see the nose is coming. Here's the cleft. Here's the eyes moving to the center. Here's where the eyes are coming to the center more. Here's the cleft, and I'm going to pause it right here. This is about 6 weeks. You can see how far apart the eyes are. And these, exactly when you think about it, and you look at patients and you say, well, there's hypertelorism, the eyes, the sockets, and you can see that this is where the embryos stopped growing or stopped changing. It didn't have normal growth. And this is how the eyes start coming together. Here's where the ears are, low set ears, another finding that we see in congenital anomalies. But now the ears are starting to move up, eyes are coming together, ears are moving up, and you can see at the end, this is what a baby would look like. So to me, this is the best description, and I'm going to play it again because it's my favorite of all time. Again, the embryo growing, again, just a few days to a few weeks, and you can see where the eyes are on the side. You can't even see the ears yet. Eyes are way on the side. The lip is coming together with part of the nose. Here's where the cleft would be. You can see how Tessier had clefts that went all the way up to the eye when he described the birth. Now you can see the lips together there. Now the ears are coming, and this is, again, ears are coming up, eyes are coming together. This is when you think about your children you see with closed set ears. Ears are going up, ears are going up more and more until the baby is born. That's the best slide I have in this whole lecture. Hearing loss is also associated with it, and you think about it when you have if you have the soft palate not together, the muscles that help open up the inner ear do not help drain and equalize pressure. So you don't have normal hearing because the ear function doesn't work well. Most of them are conductive hearing losses, very few are sensory neural. But this is what needs to be addressed when the child is little, so you can have pressure equalizing tubes placed in the ear if need be, and that's why you want an otolaryngologist as a colleague on your team, unless it's something that's within your experience and you know how to manage that. Also why we need audiologists on our team. So we can do a number of tests. All of our kids get tested at the time for auditory stimulus at the time of lip repair, but not so often on our programs. So how do we repair these? We sort of talked about how often they occur, what they look like. How do we repair them? Again, a lot of people have incredible egos. They put their names on their repairs. Some of them deserve it, some of them I'm not so sure. But this is the classic finding: complete unilateral cleft lip, incomplete unilateral cleft lip. This is when we repair them. This is the classic thing that's in the textbooks and what you would probably be asked. It's called the rule of tens, and it's based on 10 grams of reduced hemoglobin, 10 pounds, which is about 4.5 kilos, and age 10 weeks. Well, why did we decide it? So this is a newborn baby. Now, if we could repair this baby, this is just me talking without any science, but if we could repair this baby now, at the day of birth, first of all, their healing abilities would be even better. They'd be able to heal hopefully with less scarring, but there are tremendous risks in putting a 1-day-old to sleep, even though we know we can do it because of cardiac surgery and other emergency procedures that can be done. But for a procedure that's sort of elective, you can decide when to do it. The reason this rule came up as the rule of tens is because our anesthesia colleagues said, look, if we wait until about 10 weeks, the antibodies from the baby are growing, the antibodies from the mom are going down, they cross at about 10 weeks, so that when you have that, you have the most amount of antibodies there to help fight off infection, help with healing. So this is the timing, and anesthesia said this is our safest time. Now, all of us as surgeons are fairly egocentric, thinking that we're the magic that happens in the operating room, but now I'll give you some other opinions. In reality, our colleagues in anesthesia are truly the magicians, because they take a child they've never seen before, comes into the operating room, they give them drugs, they put them to sleep, allow us to cut on their face, repair something, and then they wake them up and take them back to their mom and dad. So truly a remarkable thing. I compliment them and I'm sure you do as well. They are the magic that happens, is that they allow us to do this, even though we get a lot of the credit. So this is the rule of tens. Now in Operation Smile, we don't follow this. And the reason is we're concerned about the safety of anesthesia in less developed countries. So we have rules. We don't do cleft lip repair before 6 weeks, for 6 months, and we try not to do palate repair until almost a year. There's some advantages to that and disadvantages. First of all, we see that their weight is better, their immune responses are better, and it's a larger child to work on where there's a bigger margin of safety, even though it's not the largest margin of safety. So the goal of our reconstruction is to make this correct again. This side, the muscle is intact. This side, the muscle bulge is here, and there's not much muscle here. So this orbicularis muscle should be over here, this orbicularis, and these should be connected. And the nose, the nasal septum, because it's being pulled by the muscles on this side, but there are no muscles here to pull on it, the nasal septum is deformed to one side. So when you repair this, you'd like to make sure your nasal septum is also correct. This also completes the orbicularis for the sphincter function and allows them to pucker. So sometimes it's difficult to breastfeed if you can't make this pucker. So it's more difficult, and these children sometimes have to be breastfed. So what are we trying to do when we restore this? Well, we want to make Cupid's bow look exactly as it was in an unchallenged child. We want to make the nostril sill and the lip the correct length. We want to make the septum in its correct position, and we want to make the muscles complete so that we have the orbicularis with full integrity. So this is one of the earlier repairs that many people adopted, including me in my early training. And this is called a Millard procedure. It's an advancement rotation, a number of dots and diagrams, but basically you're going to try to rotate this over and advance it into the normal place. Rotate this down so that the length would be the same. So this gets cut here, this gets cut and moved over. And Ralph Millard, who was one of the geniuses of plastic surgery, his textbook is still one of the all-time classics. This is how it's done. So you open this, rotate this down so this lip is longer. This then rotates in. But what are the disadvantages? What's the thing that's not good about this? Well, first of all, you've cut underneath the nostril. This is just not a good place to make a scar. And you've pushed this across the midline so that it looks in an awkward position. And showing you a case, this is an incomplete. And here are my markings where you try to get the Cupid's bow, and you're going to make this cut around and open this up and move this over. So this is a classic thing. You find the muscle on both sides. You can see it's being grabbed on either side. You put that together so that the muscle's together, and then you're going to rotate this across the midline to close it. And you look at that and you say, well, that's not so bad. But then again, look at the nostril. The nostril's not been addressed. They're not symmetrical. Again, showing you my case of saying, this is the way I did it 35 years ago. And I don't think this is the best way, but it should be in your armamentarium, because there are some people who still say this is the best way to do it. And I'm only critical in that this makes a scar under the nostril. That's not a good place to have a scar if you can help it. But again, at the time, this was the standard. Many of you may be trained with this technique, but I think they're better ones. So looking at what we think is a better, or what I think is a better way, is that we started changing to anatomical subunits. And this way you're able to move it by precisely doing it. The Millard, you could cut as you were going and make it fit in there, but you would get some short lips. You were cutting out some tissue you probably didn't need to cut, and you made the lateral lip shorter because you were trying to over-rotate into it. And I think the incision lines aren't as good, especially where you don't have to cut underneath the nose or underneath the alar. So this is the paper. If you've not read this, you should put this, take a picture of it, things at the bottom. This is the one that is Dr. Fisher's, who was published in July and 20 years ago, and in my opinion has become the classic or the best way to do it. And now again, other people will say, no, my way's the best, this is the way I was trained, and it works for me. Over the years, I think more of us are going to this technique. And again, it's similar diagrams where you put your marks and you mark out, but the technique, I think, and this is how many points Dr. Fisher put on it. And I look at this and I go, holy cow, I'm never going to remember all those points. That's like crazy. So he does talk about fixing the anatomic part, where you fix the filter and you fix the lip, but you only cut one time. You make your plan ahead of time. You do exact precision when you make your markings, and every single part you already know ahead of time where it's going to go. You don't have to try to guess where it'll be and then modify your cuts. And you don't have to do a big major revision. So this is ideally what we would like to see. This is normal, no abnormality. And if you could, these are the anatomic subunits. You'd like, there's an area over the Cupid's bow, over the white roll, where there's about a 2 millimeter gap here. And this is the natural flow in the subalar region into filtral ridges and into the philtrum. This would be ideal. It would be totally symmetrical with the other side. So as close as you can get to this line is what I think is the best way to do it. So these are the different ones that fit. Now the black line is what I think is ideal. Everyone would agree with that. This is Millard, where he would cross over here. And so those lines are not consistent. Cuts under here and over here. And then Tennyson-Randall is one that is similar to what we do, but it's still off of the ideal line. And that's another repair you can look up. It's one that many of us do. One of my former colleagues still feels this is one of the best ones. So if this is the ideal repair, this is the fissure repair, which I think much more closely embodies the ideal line of repair. And when you read that, if you look at this, and then the only place that's not exactly on there is this triangle that equalizes the length, and the triangle here that equalizes the width of the lip. So this is what a fissure repair would look like. And these are the points you need where the Cupid's bow would be. And again, not very many markings, but it's precise. Every point is done with calipers. You know exactly where it's going to go. You cut it one time and everything is fixed. So you make all these markings, you know exactly what the width will be. And again, when you finish it, you don't have to compromise the length of the lip or the width of the lip. The triangle that's there is very small. It's less than 2 millimeters. It's not like the long piece that goes across the midline. There's virtually no tension, and any tension is above the white roll, so you don't have any distortion there. The muscle is repaired exactly in the correct place, and there's no additional scar at the alar base. So this is a colleague of mine who did this. This is not mine. I would love to take credit. This is his repair. And to me, are you kidding? This is just magnificent. This is like one of the best repairs. So this to me is the way it should look. And this is when he's a little older, and you can see this is the line. This is the line. Here's that little triangle. And the nose is not perfect, but it's where the alar base is ideal. No scars anywhere else on the lip. So this is using the scalpel to do, oops, let me go back one. So this is again what we're going for with the fissure technique, and this one is mine. So this is mine preoperatively. This is right at the end of surgery. I think the nose is about as good as I know how to do it. This line, again, is as close, and this is a couple of years later it was sent to me. That's as good as I know how to do it. And I think that lip looks, the kid can walk down the street and no one would probably realize he had a cleft lip and palate. So that's my story about cleft lip. Lots of different repairs. Whatever you learn, if you learn to do it well, is fine. I would encourage you to read Fisher's paper just for historical, because I think it's the best repair out there now. And I don't know how to modify it to say, well, my way's better than what he did, because I've been so impressed with my results following his guidelines. And it's what I've taught residents and fellows, and certainly people in our programs that go with us in Operation Smile. So repairing the palate, first of all, you make sure you understand the anatomy of what we're trying to do. There are a number of procedures that are being presently done. Von Langenbeck, one of the classic old-time repairs. Bardock, who was my professor, it was the procedure I learned. In my hands, that's still the procedure that I like to do. It works for me. I feel like I get adequate length in the palate. And the furlough is one that was an incredibly ingenious procedure that if you have not read the paper, I would encourage you to read that. It's a great technique for repairing cleft palate. At the end of the day, why are we fixing a cleft lip? Well, we're fixing a cleft lip because we want our patients to look okay. It's an aesthetic and functional operation, but mostly you have to be able to walk down the street and be not identified as what happened to that kid, but they look fine. The cleft palate, on the other hand, is purely functional. No one's going to look in their mouth and say, oh my gosh, that's the ugliest palate I've ever seen. In fact, what they're going to do, they're going to say, if you can speak correctly, then the palate repair was done well. So if you can, and people that have cleft palate, because air goes into the nose, they speak with hypernasal speech. And it's very difficult to understand patients when they have hypernasal speech. So you can't go into a store and order something. It's difficult because you can't understand them. If we make our palate repair correct, the soft palate will close into the pharyngeal, into the back of the mouth, into the pharyngeal wall, and air won't escape up into the nose. In a cleft palate, whenever they try to close, air escapes and they have hypernasality. So all of these repairs are to try to put the muscles together so that the palate will lift. Also, make sure the palate is long enough to go all the way back to the pharyngeal wall. And the problems that we see are in palate repairs where the muscles are put together, but they're still too short. When they lift, they don't touch the back of the palate, so they still get hypernasality. So each of these have an important technique that involves make sure you're lengthening the palate. If you don't, you have velopharyngeal incompetency, which is sort of the end of this. And it means that, to me, if you've done the procedure correctly and the length is there, they'll have normal speech. You don't have velopharyngeal incompetency or insufficiency. And we could spend an entire program just talking about speech outcomes. But that's the only outcome that matters. So you want to be able to do these repairs in the appropriate time. You need to separate, you need to close the mouth from the nose. They don't have food in their nose. And you want to make sure the velopharyngeal mechanism is intact because you'd like to have normal speech. That's the only outcome that matters. So there are two schools of thought here. Should you repair this early or should you repair these late? And then the definitions of those change. And this is sort of Operation Smile's approach at this point. We would like to fix the palate before these children learn how to speak. So age 1 is a good age. Before age 2, you have a chance to fix the palate before they start making a lot of sounds that would be incorrect because their velopharyngeal mechanism is not normal. And then they have less compensatory articulation. If you repair a palate, whenever you do that, you stop some of the growth of the maxilla. So the maxilla doesn't grow as wide, so you get occlusion problems, and the maxilla doesn't grow forward, so you get jaw cranial base anomalies. And they get mid-face hypoplasia. So if you let the kids grow till they're 10 or 12 years old, don't fix the palate, their face will grow correctly, but they won't be able to speak. And as I said, the primary goal, in my opinion, is to have normal speech. So I'm a strong advocate, as is everybody in Operation Smile, try to repair the palate earlier so they develop normal speech. Even then, they still have some people who have abnormal speech, and you have to be willing to address the other abnormalities that occur because there's been some growth retardation. These are a few techniques about what's done. These are the Dingman retractors that we use to hold the mouth open. There's several people who put their names on a specific instrument. This happens to be the one that I use. The von Langenbach repair is fairly straightforward. This is incomplete. It's what it's typically used for. Incisions are made along the edge of the cleft and along the sides. Tissue is elevated, undermined, so you can advance the tissue toward the midline. You close the nose, and then you push the muscle back and close the muscle of the soft palate, creating that sphincter, and then close the mouth. These lateral defects that are here are usually not addressed. They will heal, and this just is like a bad pizza burn. It heals in about 2 to 3 weeks. But because you have stripped off periosteum here, there's some growth restriction in the width of the palate. So here's a typical example. Again, the muscles put together, small incisions on the side to be able to move that to the center. and here's the oral closure. Here are the defects on the side. VY pushback is another technique just for trying to lengthen the palate. So you take the V and push it back to a Y. You elevate so you can expose the vascular bundle on either side. These are pushed back. Muscle is repaired, pushed back. And then this is the amount of retro displacement you've put. So that is going to push this whole thing back closer to the pharyngeal wall so that you would hopefully get normal contact. Again, Janusz Bardak was my professor. It's the technique I learned. This is still the one that is my go-to procedure, but there are many techniques that all will work fine. So again, typical incisions, freeing these up. The vessels are dissected so that you can move this back. The muscle is dissected off the back of the hard palate so you can retro-displace it. Muscle is pushed back and closed. Then the mucosa is closed all the way up to the front, and that's what it would look like. And you see the muscular sling has been totally repositioned. So, talk for a few minutes about velopharyngeal insufficiency. This is mostly due to, it's air escaping, and how does that occur? You get hypernasality, and it's because the velopharynx doesn't touch. This happened to have been one of my major areas of interest. It can be done fairly easily just by your auditory examination, by having the kids say sounds that you know would normally be nasal or denasal. So, M is a nasal sound. P, 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 p is not. Ha, 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 ha. So you have to be able, you can do it just by listening and having sentences that you are comfortable with. And speech scientists will give you everything you ever wanted to. But normally you can do that with just a simple piece of equipment like a mirror. You have them count from 60 to 70, putting the mirror under their nostril. You shouldn't have humidity coming out the nose. Or you could push the nostrils together to make sure the sounds are the same both ways. There are a lot of instruments that we can use, and having been in an academic environment for my entire career, 30 years at the University of Illinois, we had all these in our office. And we had, the Cleft team was in my office. So we had everything right there where we could do cephalometric x-rays, video fluoroscopy, and we did nasal endoscopy on every kid. A simple lateral x-ray showing the soft palate. This is a 6-foot lateral x-ray, soft palate lifting up, closing to the back of the throat. And this is one with a cleft, and you say, and they go, and the palate doesn't close. Again, very simple, and it's very low dose radiation. Video fluoroscopy, you can look at both just lateral views, and you can turn them so you can see them. You can have them do nasal speech, so you can see how the soft palate is moving and what the lateral pharyngeal walls are doing, because normally they will also close to close that sphincter with a superior sphincter. And it's a very, very high-end piece of equipment. You can do it with anybody over the age of 6. You put topical anesthesia in, there's no radiation. It's a great way to do it. MRI was another way, but it's very difficult to find the right centers. This was a lot of my research. This is one of my former grad students who was doing the first MRI work to try to show what the soft palate would look like. So we could look at it in static views, but MRIs need to be functional. You want to know when this kid is speaking, do the muscles work? And when the patient is speaking after I did surgery, are the muscles working correctly then? We don't have this technology yet, but we're close to it. So this is what a normal MRI, this is the hard palate, this is mandible here, hard palate, this is the soft palate where the muscle goes all the way across. That's what it's supposed to look like. She did all these measurements to come up with what these angles should be, what the muscles look like, an incredible amount of work. We came up, with the classic thing, you could do this with an E sound, where E, your palate would close. If you did, you would have to do it, you'd know, well, there's something that's not working correctly, and you'd hypernasal speech. And that's exactly what's shown here. An E with velopharyngeal incompetency, it doesn't touch onto the pharyngeal wall. So a normal one, normal at closure, abnormal, looks just like normal, but BPI, it doesn't close. So you have an opening in the back and air escapes. So the types of treatments that can be done are pharyngeal flaps. This is when it's severe opening in the back. We did it, we had our own algorithm, which we said if it's less than a certain amount, you could do a sphincteroplasty, where you could redo the soft palate repair to lengthen it. This was a sphincter, so instead of having a hole this big in the back, you would make it so you made the sphincter smaller and tighter. And it's classically taking muscles and inserting them into the pharyngeal wall, and it makes the opening smaller, so you'd have less necessary movement of the soft palate. Pharyngeal flap is done. This is a technique this is the inferiorly based one, where you would take the mucosa off the back and sew it into the palate. It's an easy operation, but it is not the one to do. It is an inappropriate surgery. It's only in here for a historical perspective, because the inferior flap is the opposite of where your palate, if you want to close your palate, this pulls on the flap. It was an easy way to do it. So I don't know if you have any questions. I'll get out of this. I want to tell you about a couple of references. If you've not read this book, this is A Surgeon in the Village. It's from about 7 or 8 years ago. It was written by a surgeon who went to Africa and trained non-surgical players to do brain surgery, which to me was remarkable, but he saved a lot of lives. So it shows how we have to think differently. These are other books I tell residents and students to think about. The spirit catches you and you fall down. I'll show you that book. This is one that's about Hmong people that have moved to the United States. They have a large community up in Minnesota, Wisconsin. And again, it's a different culture. So for people that work in different cultures, it's important to understand, how do you understand their needs and what they want. This is about La Doctora, a surgeon who went to the Amazon and worked. Hope in Hell is Médecins Sans Frontières, which all of us know. MSF does incredible things, but this is a 20-year-old book, but it also talks about how crazy it is for me anyway to think about it. I thought about, well, this may be something I'd like to do in my life. And then I had 2 daughters, and I said, yeah, I think I'd rather be a dad than do that. And then Tracy Kidder's book. So again, these are some interesting things. This is The Spirit Catches You. It's a Hmong child in the United States in different cultures. Again, I try to spend a lot of time trying to help people learn about other things. So this is my storyline from the University of North Carolina. I'm going to see if I can get out of that now. And that, because I haven't heard from anybody, and I'm hoping people are still there. So that was my storyline. I am more than happy to field questions, criticisms, but try to give you an overview. This is what I typically give to medical students, residents, and fellows. Open it to you, Dr. Tube.
Yeah, thank you very much, Dr. Goldwasser. That was a very insightful and easy to understand lecture. I think I speak for most of us when you say that we have gotten a better understanding of cleft lip and palate. Yeah, so I'd like to now open the floor for any comments and questions. This is an opportunity for discussion. We had a question earlier from Jonathan Yaku, who wanted you to reiterate your explanation for why cleft palate is more common on the left side. Yeah, and also why it causes both conductive and sensorineural hearing loss.
Thank you. And just as an aside, I did make my second trip to Africa this past year to Malawi, which was an experience of a lifetime. So I'm so lucky I was able to do that. So the first thing is, why do they occur on the left side? Let me start out with the answer that everybody says, I don't have any idea. I have no idea at all, Jonathan, why that happens. But one of the theories, which I don't necessarily believe, but just so you've heard a theory, is that in the fetus, the normal position of the head, and if you think about when you do deliveries, normally the head is down and to the left. So it's turned like this. So the heart bulge is right next to the face. And when you look at the embryo pictures, that's how it's sitting. So there's So you think about it, perhaps there's something about the physical heartbeat beating on the left side causing some disruption in how the cells are together. I think that's nonsense, but that's one of the theories. The other is, if it's just genetic and you have more clefts on the left side, more genetic component to it, there would be more future gene pools that would have less chlorine in them and would have more left-sided clefts. That would be just a pure statistical finding. I have no idea why, and I'm sorry I don't have any more information. The second is, so why do you have the two types of hearing loss? Well, the most common one is because of the eustachian tube dysfunction, because you don't have the muscles that open the airway closed in the soft palate. The velar tensor palatini doesn't work because it's not together in a cleft. And then once you put it together, it will work better, but you still in the meantime need to make sure you've got pressure equalizing. So that's purely anatomic, easily explainable. Sensory neural, I really don't understand unless it has something to do with some of the genetic transmission of, well, this person had it, and there are probably some syndromes where it's more likely, but I don't have that database. So I struck out on both of those questions, and I wish I knew more.
Yeah, thank you very much. Yeah, I think that's a good enough explanation, and hopefully we will work on finding better explanation in our own careers. I had a question about adult patients with cleft lip and palate. Here in Kenya, we don't see a lot of them, which is a good thing. But I was wondering, like in other places which have less access to surgical care, how do you approach them?
For the adults, I do it. In the adults, I do it the same way. I do a lip repair first. Although again, it is just there's people who would say the most important thing is to get their palate together so they can speak. You should do that first. I'm so old school. I just tend to want to make them look okay in society, and then they come back and they can fix the next part, which is for feeding and speech. Some places I've been there, they say, well, if we fix the lip first, they'll never come back for their palate. And I go, you know what? They're an adult. I'm okay with that. Let them make that decision for themselves. Some of the adults who have come in say, look, if you can just fix my lip, I can get married. I can have kids. I will have a relationship because I'll look okay. And if I don't speak okay, it's not such a big deal. Well, obviously I'm a purist. I'd like them to look good and speak well. So I tend to treat them in the same manner. And if they don't come back again, no hard feelings. They're adults. If it makes their life better, I'm all in. I think that's terrific. So historically, and in some of the times I was in the Philippines, I would say, well, this is a kid who has come from 12 hours away from here. 12 hours. He's 7 years old. And he came by boat and by horse, and he may never get back to see me. I'm just going to do the lip and the palate at the same time and be done with it, and that ends that. Well, intellectually, we say, well, that's a good idea, but in fact, you have created a much longer anesthetic, which increases the complication risk. It's grueling surgery for a child to recover from both of those procedures. The complication rates I always felt were a little higher, even though I thought I was doing the same operation just, at the same time. And it meant that if I did both of those at one time, one less child was going to be treated because that would take the place of somewhere else. And we would operate 16 hours a day. That's foolish. Don't get tricked into that. Work your normal schedule and then call it a day knowing you'll be the best the next day. And that's what we try to do now. We limit the surgery to no surgery starting after 5 o'clock. And we try to get everybody out of the recovery room by 7 p.m. So it's really important to preserve the caregiver, make sure you've taken care of yourself and that you're not exhausted, which we were after every day we were exhausted. But I don't do them at the same time, mostly because there are abundance of children. And if in Kenya you don't have a big backlog, that's terrific. And if you don't see adults with it, that's terrific too. It means obviously you're doing something right, and hopefully we can get everyone else in the world to follow that lead.
Yeah, thank you very much for that response. Also, another question from Kigoto Karuku. There are times when the cleft lip has to be repaired in a series.
So there are people who believe in that, and they do either lip adhesions first because it's a very, very wide cleft. They just put it together without the muscle being together, and then allow that to help conform the maxilla a little bit just due to the tension of the scarring. It's, again, there are people that do lip adhesions and they do it sequentially. I've not been in a position where I felt that was necessary, and it may be that I don't have enough experience with some of those cases, but I try to limit the number of anesthetics, which is the biggest risk factor is the catastrophic events from anesthesia. So I try to do one lip operation, one palate operation. I'm hoping that's all I ever have to do. If I have to do a speech operation later, I will do that, but it's because I failed at my palate operation. There's certainly lots of complications from lip and palate surgery, and we see these on every program we go on. We see complications, and I just hope that few of them are mine. But I do, I've certainly had complications in my career, and I see some of them and I go, oh my gosh, how did that happen? And, a necrotic flap or somebody cut an artery, and I go, oh my goodness, but it can happen. And those patients get sequential surgery because you're fixing something. And the second time you go in or the third time you go in, it's always more difficult because there's more scar tissue. So obviously I try to do 2 operations, and if I didn't do the second one very well, I have to do a third. And if that doesn't work, I'd like to find a colleague who would hopefully bail my patient out.
Yeah, that's for sure. Thank you very much. There is one more question from Dr. Aiko, who has raised her hand. So you can unmute yourself and ask your question. Okay, Dr. Aiko, I think you might have raised your hand by mistake, so it's okay. So with that, I think...
Hello.
Yes.
Thank you, thank you, Dr. Goldwasser, for such an enlightened presentation. Please, I wanted to find out something. It's a bit personal. I wanted to find out if we take students from Africa for observership.
Dr. Tu, could you repeat that? There was some background noise. I couldn't quite understand.
Please, I wanted to find out if you take students from...
As a fellowship, I do not know if they take students. We do not. But I'm sure there are a number of places who accept fellows from anywhere in the world. I just am not familiar with which one. I understand that. I don't know. We don't here at North Carolina, but certainly we have students. So I don't know is the bottom answer. We know we don't here, but I know there are places throughout the United States that do take surgeons and students from Africa for fellowship and observership. Absolutely. It's the best way for us to exchange information. We learn from you, you learn from us.
Yes. Thank you very much, sir.
You're welcome. I would like to thank you very much for asking me to participate in my world at the University of Illinois. 50% of my practice was on skin cancer. 25 to 30% was for cleft and craniofacial. And the rest was mostly trauma and reconstruction. So this is one of my true passions, and when Alice asked me to help create this year-long program, these were the areas that I thought would be most interesting that I could work on. I have a daughter who's a surgeon, and she felt this was a reasonable thing in what she would put together for plastic surgeons. If there are things that you would like to hear about that are different, any of you may write to me. My email is public and it's on Operation Smile's website. You can send me a note, and I can certainly work with Alice or Dr. Tu or anyone to try to invite some other colleagues that would have specialties that you might be interested in or areas of plastic surgery. So again, it's an honor to be part of this. It was an honor for me to be invited to come to Malawi to work as a surgeon there. My only other time in Africa was to Northeastern Africa and Egypt, and had another incredible experience. So again, I'm a very lucky guy to be able to be involved in this and to have taken care of so many children over the years and be a part of your process as well. I hope our paths will cross someday and I will get a chance to work alongside of you. So thank you for the kind opportunity.
Thank you very much as well, Dr. Goldwasser. We really enjoyed your talk, and also thank you for your support for AfroPRS, and we hope to engage you further in the future. Also like to thank our members for their attention and for asking also those good questions. Yeah, and if there are any announcements from the members of the AfroPRS team, you can also do so as we conclude. But thank you all for your participation, and I hope you have a great week ahead, and hope to see you soon again.